This presentation was created by Dr. Donald Juravich. This is part 2 of the Geriatric 4Ms medications presentation. This is part of the program for the Dakota Geriatrics and the HRSA supported Geriatric Workforce Enhancement Program to strengthen older adult healthcare. The goals for this presentation include how to screen patients for unsafe medications, how to optimize communication for deprescribing, and then how to eliminate or reduce the burden of unsafe medications in the older adults. What is the deprescribing process? Is there a way that we can systematize the process in a clearer way and make it more consistent as we practice the 4Ns with each clinical encounter? What is the definition of deprescribing? From this article, we call it a process of withdrawing inappropriate medications under the guidance of a healthcare professional with the goal of improving outcomes. We always need to ask, what are those outcomes? We will talk about one of the process measurements that we can judge ourselves by or analyze how well we're doing with the deprescription process as part of a quality improvement initiative. With communication during the deprescribing process, we mentioned earlier in the other presentation that we want to be mindful of the psychological connection to prescriptions that people have. We also want to promote, as in all aspects of clinical care, a shared decision-making process, which should also include the caregiver. We often overlook that. When reviewing the medications under our 4M framework, it's important to ask whether one or more of these medications are making any difference for the patient. Are they helping the patient? That might be an opportunity for deprescribing or exploring the possibility of discontinuing the medication. We want to emphasize the psychological connection to medications. These are different quotes from a quality data research program. You can see the different responses that the patients have had when asked about this. The second point here is, do you know what you're doing if you ask about taking away a medication? People might challenge you in your knowledge because one of their doctors from a long time ago gave them this and said they have to be on it for life. There are many points here that we need to be mindful of and respond to as we interact with the older adult. There are different methodologies for deprescribing. This JAMA article walks you through the steps of establishing the medications and what they're used for. To illustrate, a patient will be asked why they are using gabapentin, and they respond, "I don't know. My doctor gave it to me." They don't have a connection as to why they're taking it, but they're somewhat dutiful and following doctor's orders. It's important to determine overall risk for drug-induced harm. This is why we have these lists, such as the Beers list, to identify classes of medications that are clearly harmful to older adults or potentially harmful. The third point is whether that medication is absolutely needed or is it something that we could consider discontinuing. This is particularly in the case of SFRIs. If you're treating mild to moderate depression, there's probably a higher likelihood that you can try to reduce or discontinue the medication, as opposed to somebody having a severe history of depression where they may need more long-term use of it. Number 4 is to identify the medications that you would like to discontinue and do it in small steps. Don't get rid of all the medications all at once. This is an approach from the Australia Drug Management System. The question is, when and for whom is deprescribing appropriate? On the left with the WHO section, we see that it's people who are frail and individuals that have chronic kidney disease or advanced chronic kidney disease. The deprescription process should occur at all junctures of healthcare transition, particularly when a patient is being discharged from a hospital on an antipsychotic that was used for delirium. There should be a hard stop date if they're transferred to the long-term care facility. As an example, the process is enhanced by a brown bag audit. This is when geriatricians go to public housing to meet with folks on a one-on-one basis to review their medications. This was to encourage them to talk to their doctor about possible unnecessary medications and document what was discussed. This is why we document the 4Ns correctly. Under medications, list what the unsafe medication is and then whether you want to deprescribe it along with the reason why. Yes, the SSRI is an unsafe medication, but it is necessary for maintenance of therapy for depressive symptoms. That comment would complement what you're saying or evaluating in the other 4M of mind, where you would then document the PHQ-9 to show that you are adequately maintaining antidepressive therapy. The PHQ-9 score should be 4 or less. What is the deprescribing efficiency or efficacy? This study shows from ages 65 to 80, there's a massive peak in prescriptions that are occurring. As people advance beyond the average life expectancy of the age of 81, those prescriptions decline. People that are surviving to 81 and longer are very healthy, long-lived individuals who don't need a lot of medications or have a low chronic disease burden. There is ample evidence that deprescribing works. There has been meta-analysis and multiple studies. One of the studies cited from Australia showed that with a dedicated deprescribing program, it's possible to reduce the overall medication on average by 2 medications after the process. Deprescribing works. One study shows there were up to 4 fewer medications for the older adult. As a result, there was better quality of life reported by the older adult participants in the study. There have been several studies looking at antipsychotic reduction, and these studies show that the reduction had no impact on change in symptoms. It helped reduce falls and had small incremental improvements in cognition for those transitioning from antipsychotics to not taking the antipsychotics. In North Dakota, our nursing home patients still persistently have high levels of antipsychotic use relative to the national norm. We have a lot of work cut out for us to deprescribe antipsychotics in long-term care. A group of geriatricians were asked which medicines were the least liked. Here's the top of the list. In everybody's list was benzodiazepines because of their potential for cognitive impairment, amnesia, and fall risk. The same is true for typical antipsychotics, which some research indicates that about 13 to 15% of dementia patients will benefit from antipsychotics for behavioral control. But again, the vast majority of the individuals with agitation and dementia do not benefit from antipsychotics over the long run. Statins, particularly in the oldest old, don't make sense. Tricyclics have side effects, including hypotension. PPIs, number 5, are associated with increased incidence of community-acquired pneumonia, osteoporosis, and some new indicators of cognitive impairment. As part of our project for Age-Friendly, we want to identify potential opioid misuse and to educate people on deprescribing that class of medications. When you do your assessments, most people refer to the Beers list. There are other tools that could be used, but the 2 systematic tools that have been used are the Beers list and the Start-Stop program generated out of Ireland. Here are some of the targeted medications, in addition to the consensus list, that we want to be mindful of. The first-generation antihistamines and Tylenol PM. Sulfonylureas are associated with hypoglycemia and are to be avoided. It's the reason why metformin continues to be the first-line treatment for type 2 diabetes. Vitamin E increases the risk for hemorrhagic stroke. Some research suggests that chronic vitamin E use shortens your lifespan. Multiple vitamins are probably not necessary with the exception of vitamin D supplementation. Bisphosphonates will last for an eternity in the bones, and it's not clear that long-term use of these changes outcomes. Be mindful of what might happen when you prescribe a high dose of prednisone. It is one of the most anticholinergic medications that we prescribe, and it can predispose people to delirium or mental status changes. Amiodarone for cardiac arrhythmia and atrial fibrillation has a high impact on older adults with fatigue, and it's the well-known drug induction of hypothyroidism. Nitrofurantoin can cause problems with electrolyte disorders and worsening renal function, particularly in those that already have low renal function, so this is to be gingerly used in the older adult population. The use of mineral oil as an over-the-counter for constipation in older adults has been associated with lipoid aspiration pneumonia. With all of this deprescribing, how do you track it? There's different methodologies, but this is a mock-up of what we might expect if we had 5,000 patients in our clinical practice. Let's say we identified 3,000 unsafe medications or potentially harmful medications, and we systematically applied the 4Ms. From month to month, we would see that the number of unsafe medications should decline over time. You can convert this data into overall medication burden, number of pills per patient, for example, or you could do anticholinergic burden and track that over time if you want to focus on that. You could look at opioids too, by looking at the number of patients that we've referred for opioid misuse evaluation through our consultant pharmacist. That would be another wonderful metric to show our efforts towards the deprescribing process and thereby enhancing safety for the older adults. In conclusion, it's important to prepare the patient for reducing medication burden. A lot of times, they're happy to do so. Some reason they are taking too many medications, and others are dedicated to their medication because a doctor prescribed it to them and said to never come off of them. These are barriers that you have to address. The use of the Beers list is encouraged. You can download this from the American Geriatric Society, or the Dakota Geriatrics Program can provide you with a Beers list. When prescribing a new prescription, stop and think if this is being prescribed to address a side effect of another medication. This is particularly true in situations with either constipation and/or diarrhea. And then people prescribe Laramide, which is anticholinergic, and then they're on Flexeril. And then all of a sudden, the anticholinergic burden skyrockets, so you can see how these things can escalate. Here are our resources. We have the Dakota Geriatrics website, which also has some presentations from our faculty pharmacists that talk about the deprescribing process, the American Geriatric Society, and the Beers list. The Canadian website has more practical resources for individuals. They're a little bit more evidenced. Both sites have resources and tools for the clinicians. As a reminder, please practice the geriatric 4Ms with each clinical encounter, create an assessment, and then create an action plan linked to each of those assessments. Thank you for your attention.